A teenage girl wakes up and reaches for her phone. By the time she lifts it, a blister has already formed where her thumb pressed the screen. She pulls back the sheet, and the friction leaves her skin raw. This isn't clumsiness. This is epidermolysis bullosa, a group of genetic disorders where the skin lacks the structural proteins that hold its layers together. Every touch becomes a wound. Epidermolysis bullosa, often shortened to EB, describes more than 30 related conditions that share one devastating feature. The skin blisters and separates with minimal trauma. The name comes from Greek and Latin roots meaning outer skin, blister, and loose. In healthy skin, proteins like collagen 7 and keratin anchor the epidermis to the dermis below, creating a resilient barrier. In EB, mutations disrupt those anchors. The skin becomes as fragile as tissue paper. Some forms appear at birth, others emerge in childhood or adolescence. Severity varies widely, from localized blistering on the hands and feet to systemic involvement affecting the mouth, esophagus, eyes, and internal organs. There is no cure. Treatment focuses on wound care, infection prevention, pain management, and nutritional support. For a teenager living with moderate to severe EB, ordinary life becomes a calculated negotiation with pain. Getting dressed requires soft, seamless clothing and careful movements to avoid shearing force. Eating can be difficult when blisters form inside the mouth and throat. Repeated scarring in the esophagus may narrow the passage, making swallowing painful and increasing the risk of choking or malnutrition. Walking causes blisters on the soles of the feet. Writing by hand can open wounds on the fingers. Even a hug from a friend or family member must be gentle, calculated, and brief. Social isolation is common, not because patients want to withdraw, but because explaining the condition over and over becomes exhausting, and the risk of accidental injury in crowded or active environments is real. Adolescence compounds the difficulty. Teenagers are building independence, forming relationships, and navigating a world that prizes physical activity and appearance. EB disrupts all of that. Chronic pain, frequent medical appointments, and visible scarring set patients apart. Some experience depression or anxiety. Others develop remarkable resilience, learning to advocate for themselves in medical settings, adapt their routines, and educate peers. But the physical toll is unrelenting. Blisters must be lanced, dressed, and monitored for infection daily. Bandages become a second skin. In severe cases, fingers and toes may fuse together as scar tissue accumulates, a process called pseudosyndactyly. Repeated trauma and chronic inflammation also increase the risk of aggressive squamous cell carcinoma, a type of skin cancer that can develop in areas of long-standing wounds. The diagnostic process for EB begins with clinical observation. A newborn or young child presents with widespread blistering after minimal handling. The pattern of blistering, its depth, and its distribution offer clues. A skin biopsy, examined under a specialized microscope, reveals where the separation occurs. Within the epidermis, at the junction between the epidermis and dermis, or deeper in the dermis itself. This distinction divides EB into three main types. Simplex forms involve mutations in keratin genes, causing blistering within the outer layer. Junctional forms affect proteins in the basement membrane zone, the anchoring layer between skin layers. Dystrophic forms result from mutations in the gene that produces collagen 7, leading to subepidermal blistering and severe scarring. Genetic testing confirms the specific mutation and helps predict disease course, though considerable variation exists even within families carrying the same mutation. There is no single moment when the case turns. EB is a chronic, progressive condition. But there are inflection points. A wound that will not heal becomes infected, requiring intravenous antibiotics. Scarring in the esophagus becomes severe enough to require dilation, a procedure where a balloon or rigid instrument is passed down the throat to widen the narrowed passage. Malnutrition develops despite attempts to eat, and a feeding tube must be placed directly into the stomach. These interventions do not reverse the disease. They manage its consequences and buy time. Some patients undergo experimental treatments, including bone marrow transplants aimed at replacing defective skin cells with healthy donor cells, or topical gene therapy designed to deliver functional copies of the missing protein directly to wounds. Early results have shown modest improvement in wound healing and blister reduction in small clinical trials, but these approaches remain investigative, expensive, and not universally available. The mechanism behind EB is well understood at the molecular level, but that knowledge has not yet translated into a definitive cure. The proteins that anchor skin layers together are large, complex, and difficult to replace or repair. Gene therapy must deliver the corrected gene to enough cells in the right location for a sustained period without triggering an immune response. Protein replacement therapy faces the challenge of delivering a functional molecule through the skin barrier. Bone marrow transplantation carries its own risks, including graft versus host disease, infection, and treatment-related mortality. Each approach represents progress, but none yet offers a complete solution. Meanwhile, standard care remains labor-intensive and demanding. Dressing changes can take hours each day. Pain control requires careful balancing of medications to avoid dependence while maintaining quality of life. Nutritional support, physical therapy, and psychological counseling are essential but not always accessible. For the teenager living with EB, the future is uncertain. Life expectancy varies by subtype. Patients with mild simplex forms may live normal lifespans with manageable symptoms. Those with severe junctional or dystrophic forms face higher risks of infection, malnutrition, and cancer. Some do not survive childhood, others reach adulthood, build careers, form families, and become advocates for research and awareness. What remains consistent is the daily burden. Every touch is a potential wound. Every wound is a potential infection. Every infection is a setback. And yet, patients adapt. They develop strategies for wound care, modify their environments, and find ways to participate in life despite the limitations. The resilience required is extraordinary, and it is rarely acknowledged outside the EB community. This video is based on publicly documented medical case information and current understanding of epidermolysis bullosa. It is intended for education and storytelling only. It is not medical advice. If you are experiencing concerning symptoms, consult a licensed medical professional. EB is not one disease, but a spectrum of conditions, each with its own genetic cause, clinical course, and prognosis. What is true for one patient may not apply to another. Research continues, and incremental advances in gene therapy, protein replacement, and wound care are improving outcomes for some. But for now, the teenager who wakes up with blistered hands is still managing a condition that medicine can support but not yet cure. Medical mysteries. Every symptom has a story. Every patient deserves to be heard. Medical disclaimer. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes only. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician immediately.